Good evening, everyone. On behalf of MacLeod's Pharmaceuticals, we all welcome you to this evening webinar on dyslipidemia and the place of bempedoic acid, which is a recent introduction into the Indian market. We all know that dyslipidemia is a relatively common problem in India, and especially so in diabetics. So it is known fact that 25 to 30% of Indian population in the urban is dyslipidemic. And when we talk of the rural, it becomes 15 to 20%. To enlighten us further on this topic, we have Dr. Kamal Sharma, who's a renowned cardiologist. Sir is an interventional cardiologist at UN Mehta ICRC Ahmedabad and SAL Hospital Ahmedabad. Sir is also the associate professor at BJ Medical College. Sir has been awarded 22 gold medals during his medical studies, which I believe I have not heard till date. Discovered winking coronary sign, which is now called the Kamal Sharma sign in angiography. Sir did first vagal nerve stimulation device implant as part of Anthem study in refractory heart failure. Sir has been principal investigator in multiple trials, and to name a few, Paradigm HF, Atlas TIMI, TIPS, Seraphim, and Canvas studies. Sir has been the author of 8 books and many chapters. Sir has published more than 205 articles in renowned journals, and Sir is the only cardiologist to have cleared the civil services examination in first attempt. So welcome, Kamal Sharma, sir. It's a pleasure to have you. We have with us Dr. Manoj Chawla, sir. Sir is director and consultant diabetologist at Leena Diabetes Care and Mumbai Diabetes Research Center at Andheri West. Sir is associated with multiple hospitals in Mumbai, which includes PD, Hinduja Hospital, SL Raheja, Mahim, BSES Municipal General Hospital at Andheri West, and Arogya Nidhi Hospital at Vilepale. Sir has been the organizing secretary of Diabetes India 2022. Sir has been the honorary visiting faculty at D.Y. Patil Institute of Medical Sciences at Navi Mumbai. Sir is the associate editor of International Journal of Diabetes in Developing Countries, IJDDC. Sir is the Technology Task Force Master of RSSDI, which is currently ongoing in Chennai. Sir has been the principal investigator in various global trials for new chemical entities as well as devices. And Sir has published more than 25 papers in national and international journals. Welcome, Manoj Chawla, sir. With this, I would like to hand over to Manoj Chawla, sir, to enlighten us further.
Thank you. Thank you, Dr. Amit. And thank you, MacLeod, for getting us together for this interesting session. Let me start by sharing the screen. And I'm going to be giving a brief outlay of this new wonderful molecule that we have in the space of lipids management, bempedoic acid. I hope my slide is seen and I'm moving to the full screen mode.
Yes, it's visible
now. Okay, excellent. So let's move. Where really the question comes, where are you going to be using this other agent? And people ask, do we need another agent here? So it's an adjunct to diet and maximally tolerated statin therapy. Many of you would agree that there are going to be segment of patients who do not respond or tolerate higher doses of statin therapy. And also specifically for treatment of adults with the condition of HFH, which is heterozygous familial hypercholesterolemia, or even presence of established atherosclerotic cardiovascular disease who do require additional lowering of LDL cholesterol. And the good thing is it has no contraindications for this. How does it work in its pharmacokinetics? You have a half-life of 3.5 hours. Importantly, food has no effect on its bioavailability. It is the prodrug which gets converted into the active metabolite, ASCVL1, which does the action there. No time-dependent changes. Plasma protein binding for bempedoic acid, and its glucuronide and its active metabolites is respectively between 99, it is then around 99%. For its metabolism, the elimination of bempedoic acid is through the metabolism of acyl glucuronide, which is its metabolite, converted to inactive glucuronide conjugates by the enzyme UGT2B7, a half-life of 21 plus hours, excreted 70% through the renal route and 30% in feces, and has a less than 5% of total clearance. So it's largely the metabolite. The dosing is pretty clear. It's 180 milligram once daily, so you do not have any up or down titration. Oral once daily tablet taken with or without food, and it does not need to be titrated. In patients with renal impairment, you can use the same dose, except in patients who are on receiving renal replacement therapy like dialysis. It hasn't been studied there. And for hepatic, uh, there's an error here. It's not renal, it's hepatic. You do not require any dose adjustment in hepatic impairment. For child's book category A and B, patients with severe child C, this has not been studied and should not be used there. So let's understand how this works. In the cholesterol pathogenesis, it is citrate which gets converted by ATP citrate lyase to acetyl-CoA, which in the presence of SM and HMG CoA synthase will then converted to HMG CoA, which under the presence of HMG CoA reductase will get converted to cholesterol. Now, we do understand that statins work at this level between conversion of HMG CoA to the formation of cholesterol as HMG reductase inhibitors. And now you actually have a drug which is going to be working much earlier in the pathway, which is going to inhibit. You'll have bempedoic acid, which is the prodrug, which, as we said, ASCVL1 gets that's distinct to its glucuride, which is the molecule, which is the metabolite working, which is inhibiting the ATP citrate lyase at this stage, and thus inhibiting the further pathways leading to formation of cholesterol. You look at it from a different angle, a different graphic. The mechanism of action and physiological sites of bempedoic acid metabolism, activation, biological activity, and clearance. So you look at, again, the same pathway here. As we said, bempedoic acid, ASCVL1 to the bempedoyl CoA active drug is going to inhibit the ATP citrate lyase, prevent the pathways from citrate down towards HMG synthase, reductase, and cholesterol synthesis. This is how this drug works here. The conjugates, as we said, are going to be excreted through the renal and the liver pathway. You see, the impact of statins largely is how statins work is at the HMG CoA reductase inhibitors, and you have the bempedoic acid working earlier. You also have other drugs which are working on LDL cholesterol. We've already spoken about how bempedoic acid works. We've spoken about how statins work. To throw all into perspective, you have your PCSK9 inhibitors, which is inclisiran. Where does it work? So it works at the level of causing upregulation of the LDL receptors. So the PCSK9 inhibitors, by inhibiting PCSK9, they reduce the LDL receptor degradation and hence cause upgradation of LDL receptors. So more LDL receptors are present, which reduce the LDL cholesterol itself. Or then you have ezetimibe, which largely works at the level of reducing the cholesterol uptake from the intestinal level. So 4 larger group of drugs: statins, PCSK9 inhibitors, ezetimibe, and now bempedoic acid. The intensity of lipid-lowering treatment, what do different drugs do? So you have the moderate intensity statin, which will reduce LDL by 30%, high intensity, which will do by 50%, high intensity statin plus ezetimibe 65%, PCSK9 by 60%, and then you use add-on drugs and increase the efficacy to 85%. Let's understand the safety for bempedoic acid. As we said, no renal impairment, no hepatic impairment affecting it, except in severe renal insufficiency or hepatic, avoid. Assess serum uric acid when using this clinically. That's what is indicated. So those patients who have history of hyperuricemia or gout, keep a watch on the uric acid because that can increase here. Patients who are more than 60 years of age taking steroids or quinolones with renal failure and a history of tendon rupture, there is a potential for tendon rupture, and advise patients to treat their tendon rupture or tendonitis or watch for that if something happens like this to patients on bempedoic acid. Patients who are more than 60 years of age taking steroids or quinolones with renal failure and a history of tendon rupture, discontinue that immediately. Patients taking simvastatin dose more than 20 milligram or pravastatin more than 40, you avoid the concomitant use with bempedoic acid. Consider lowering dose or switching the statin. So best used with your, if at all in combination with rosuvastatin and atorvastatin. Avoid this in pregnancy and not recommended during breastfeeding. Let's quickly look at the evidence for this drug. And the evidence comes through the CLEAR program, which looked at different aspects. CLEAR Harmony, a 52-week study. You are, again, CLEAR Harmony and CLEAR Wisdom. You had about 2,230 patients here, predominantly with ASCVD and some with other indications and comorbid conditions as well. You had CLEAR Wisdom, This was on the background of maximally tolerated statin therapy. And then you have Clear Tranquility, a 12-week study with 269 patients, 60% hypertensive, 19% diabetic, where in this patients, the patients were either not on any statin or very low dose statins as background therapy in both the Clear Serenity and the Clear Tranquility programs. So we look at the data from Clear Harmony, 2,230 patients with ASCVD or the familial hypercholesterolemia or both. Patients had to have an LDL cholesterol at least 70 milligram while receiving maximally tolerated statin therapy, and plus additional with or without other additional lipid lowering therapies. They were randomized in a 2:1 arm ratio to receive bempedoic acid or placebo. So one arm was placebo and two arms were bempedoic acid. Your primary endpoint was safety, and principal secondary endpoint was to see further percentage change in LDL cholesterol at week 12 from the 52-week trial. What it shows was that by addition of bempedoic acid to these patients who had already taken statin with or without another lipid-lowering therapy, there was early and sustained reduction in LDL cholesterol. And you were able to appreciate the lowering of LDL cholesterol as early as 4 weeks in this trial. And important to see that till the end of 52 weeks, that is largely remaining sustained. And the primary efficacy endpoint, as we can see, was achieved here with a 15% further reduction in LDL cholesterol. You're also seeing benefits of early and sustained reduction in non-HDL cholesterol and ApoB levels in the bempedoic acid arm. So you're seeing the non-HDL cholesterol and the mean ApoB going down. What about inflammatory markers? hsCRP reduction in 1 month, which was seen. So you see that the hsCRP 1 month and something which is persisting till the end of 1 year. So again, additional benefits in the secondary analysis. You can look at the data from the different subgroups to see these benefits, and you do not see much difference between male and female patients. You clearly are seeing statistically significant benefits in both the sexes, irrespective of the race they belong to and irrespective of the age, whether less than 65, more than 65, similar benefits. Similarly, in this less than 75 and more than 75 subgroup analysis as well. Patients with atherosclerotic cardiovascular disease or without that, again, you are seeing benefits in both these arms and in patients with or without the heterozygous familial hypercholesterolemia. So across these segments, you saw benefit for bempedoic acid. You further look at those patients who were on low or high statin therapy, you're still seeing benefits in both these segments, with or without ezetimibe, with or without fibrate, whether the baseline cholesterol LDL was more than 100 or less than 100, with or without history of diabetes, irrespective of the BMI or the geographic region. Clear Harmony concluded that in this 52-week trial, bempedoic acid added to maximally tolerated statin therapy did not lead to a higher incidence of overall adverse events than placebo and led to significantly lower LDL cholesterol. We look quickly at the Clear Wisdom randomized clinical trial. Again, a wonderful study. You had about 496 men and 283 women, adults with atherosclerotic cardiovascular disease and or familial hypercholesterolemia with an LDL cholesterol which was more than 70. So as we understand for this population, you want to bring it down to less than 70. So despite being on statin, optimum statin therapy, if the LDL was more than 70, they were included in the study. Mean age was 64 years, 86 clinical sites across North America and Europe. The 799 patients here were randomized and analyzed again in almost like a 2:1 arm, 522 patients going on to bempedoic acid, 180 milligram for 52 weeks, and one arm on placebo. Primary outcome was the percentage change in LDL cholesterol level. What did we see in this study? The mean change in LDL cholesterol at week 12 for bempedoic acid was 15.1% reduction. So that's an additional benefit that your mean LDL was at baseline for this was 120, and you could get it down to 97. Placebo, you obviously didn't see much change there. So the difference between not adding any drug, which is placebo, and bempedoic acid rose to 17.4%. We look at another study, which was Clear Serenity, bempedoic acid, and hypercholesterolemia with statin intolerance. These were the patients who were on minimum statins or not on statins in these studies. This one is the one with statin intolerance. Double-blind, placebo-controlled, phase 3 randomized clinical trial, 345 patients with hypercholesterolemia or history of intolerance to at least 2 statins. Randomized 2:1 again for 24 weeks to either bempedoic acid 180 or placebo. So we can see the 2:1. Primary endpoint was again change in LDL cholesterol. So these were patients who were not on statins. The earlier 2 studies were patients on statins. And what you see here, effect of bempedoic acid at week 12, well, doesn't come as a surprise. You're seeing almost a 24% reduction in LDL cholesterol, a 0.4% in non-HDL cholesterol, total cholesterol coming down, 19%, sorry, non-HDL cholesterol, 16% for total cholesterol, almost 16% for apoprotein B, and about 25% reduction in the inflammatory marker like HCRP. And that's the data that we are showing from there. What was mentioned earlier in terms of reduction in LDL, apolipoprotein B, and CRP. And this again, like what we saw the data earlier, irrespective of the age, BMI, background statin or no statin therapy, history of diabetes or no, you're seeing benefits across the spectrum for the bempedoic acid arm as compared to placebo. And that's heartening to see that you're seeing this benefit across. So in terms of safety, although bempedoic acid acts on the same cholesterol biosynthesis pathway as statin act lower down, this is acting right up. The muscle-related adverse event rate in clear serenity with bempedoic acid, which is actually not activated in the skeletal muscle, unlike the statins, which work through the muscle, and hence the chances of muscle side effects are higher. Here, for bempedoic acid, they did not differ from placebo, even among those patients who had experienced muscle-related symptoms while on statin. And I think that's clearly one of the areas where our patients who are not able to tolerate lipid-lowering therapy can get benefit with bempedoic acid. We then move to looking at the study for efficacy and safety for bempedoic acid added to ezetimibe and statin intolerant patients. So this is another group. Again, in this segment, patients are not on statins, but they're on ezetimibe. And here, after 4-week ezetimibe run-in period, patients are randomized 2:1. So on top of ezetimibe, you are adding to 2 arms bempedoic acid and to 1 arm placebo. Your primary endpoint again is percentage change in LDL cholesterol. What do you see at the end of 12 weeks for LDL cholesterol? On top of ezetimibe, you're getting a further 23.5% reduction in LDL cholesterol, 18.4 for non-HDL, 15 for total cholesterol, apoprotein B coming down by almost 15%, and again, HSCRP down by 32%. So almost consistent results, whether used with statin, without statin, or top of ezetimibe, you're seeing that further reduction. Important to remember that you start seeing the reduction in all its trials as early as 4 weeks. So the benefit of bempedoic acid coming in much earlier. The effect on LDL cholesterol after 12 weeks remains sustained. Persistent hypercholesterolemia despite maximally tolerated statin therapy. You are seeing that benefit getting sustained, 16.5% in clear harmony, 15% in clear wisdom, 23%. These are non-statin patients, so hence you are getting benefit, and more benefit than you could see in statin-treated patients, because they were already getting that reduction because of statins. Those not on statins, you are seeing 23.5% and 23.6% here for bempedoic acid. HSCRP, again, you've seen consistent results, reduction anywhere from 22 and 18% in the clear harmony and wisdom, and 32 and 25% in the tranquility and the serenity data. Pooled analysis of 4 phase 3 pivotal trials, and when we look at the overall adverse events for this, hyperuricemia is something that we look out for in bempedoic acid. Gout, again, slightly higher chances. Elevation of liver enzymes, not much of a concern. Anemia may be a factor that you look at. Tendon rupture concerns in some, but a small number. Or any worsening of diabetes, you see that much lesser than placebo. So that is the other concern that you have with statins about worsening hyperglycemia or new onset diabetes as seen in the statin trials. That's not there. So where really is the place in therapy? LDL cholesterol reduction in patients not on target with statins or patients intolerant to statins. And that's where I bring you to an end of introduction of bempedoic acid and hand it to the next speaker, Dr. Sharma, to take this ahead.
So should I share your slides?
Yeah, please go ahead. Hi, good evening. Thank you, Dr. Manoj, for a wonderful talk. Thank you for having me for this topic. Well, my talk is not very much about purely talking about bempedoic acid, but we are looking at in terms of the Lipid Association guidelines and how we can position this therapy. That's what we are going to look at. So the evolution of men, as we know, from the monkey to the techno-savvy but health unsavvy overburdened, obese men. Next slide. And for this to happen, we have evolved into the lifestyle disorders. And we now know that the hypercholesterolemia amounts for 13% of the patient, hypertriglyceridemia, almost 30% low HDL in majority patients, 72%. Only no lipid abnormality in Indian studies has been found in 21%, which practically means that 4 out of 5 men in India from the ICMR India B study actually have dyslipidemia. And this is a big study, actually, 2,000 plus patients in this study. Next slide, please. So we know of something called as YY paradox. Two Guy Yagnik and Yadkin both have undergone a BMI, who have similar BMI, but their fat assessment when was done as per this paper published in Lancet, two guys, similar BMI, but different fat content in the body. So the visceral fat is 21% in Indians as compared to Caucasian counterparts of where they have BMI, visceral fat of just 9%. Next slide. So this YY paradox actually leads to a lot of obesity associated metabolic syndrome, and the triad of diabetes, obesity, and metabolic syndrome is actually predominantly present in almost 60% plus population. So we developed vascular disease almost a decade earlier. Actually, our own paper, which we published in the Oxford Press Journal of QJM, that the vascular age of Indians was almost 8.6 years more as compared to their chronological age. So for somebody who's an Indian whose age is 50 years, his age of his vasculature is like 60 years, 68 years. So it may no longer be considered a disease of affluence. It's a disease of genes, and it's also genes of thrifty genes, and a lot of disease is prevalent in Indians as well. Next slide. So we also know that the cumulative effect of cholesterol in cholesterol years is something that we all must comprehend. Shapiro had proposed this in 2020, that once you cross a threshold where of the cumulative product of the cholesterol that you have cultivated over the years, then once it is crossed, that the likelihood of the disease happens. And hence the patients of severe hypercholesterolemia, because of inherently high cholesterol at birth, by the time they reach their even second decade of life, they tend to cross the threshold and develop hyperlipidemia associated ASCVD. And this can actually be delayed when the lifelong low LDL cholesterol, which is influenced by genetics, excellent lifestyle, and LDL lowering therapy, can actually delay crossing the threshold, and hence the longevity that can be achieved with good LDL and good cholesterol control. Next slide. So absolute LDL lowering correlates with CV reduction has been known both in the primary and secondary reduction. If you were to plot LDL values on the x-axis and event rates on the y-axis, you will see that they all trials, the mean values achieved would fall into a straight line. And if you were trying to extrapolate it down to 0%, you will realize that the zero event rate can be achieved in terms of vascular events or secondary prevention at a cutoff of something like 39 or below. So for every 1 millimole reduction, which is 40 milligram percent reduction over 5 years, you have associated 23% reduction in major coronary events, and vascular events are reduced by 21% with a threshold of around 39 milligram per deciliter of LDL cholesterol. Again, a paper published by CTT collaborators in Lancet way back in 2025, almost 2 decades back. Next slide. So the lower the better. This again, the same concept that I was talking about, which was proposed again and extra evaluated by the statin arm and by the Perk et al. Recently in the Prevention of Cardiovascular Disease journal in 2022. The lower you achieve in all the trials, 4S, lipid, KRH, PS, TNT, the lower is the event rate. So if you were to extrapolate this line to 0, the cutoff would come to 50s and 30s for the primary and secondary prevention data. Next slide. So the residual CV risk, despite you have given statins, you have given and try to break down the patient's LDL to as low as you can. But despite that, in all the trials, starting right from the 4S to the TNT, there is a residual risk that happens in the patients even on the high dose statin arm. So you have patients like in TNT, you add atorvastatin 80 milligrams, or even cards where diabetes, this irrespective of lipids, the patients were put on statins, or ascortam, when you look at the hypertension or lipid lowering arm, there was a residual risk, and the event rates continue to happen in the range of ranging from 3% to 10 or 19%, depending on which trial you're looking at. And that's the target which we are looking for further reduction despite the high tolerable doses of statin when there is residual risk, you would choose and look at the therapies beyond statins, which includes ezetimibe and now bempedoic acid. Next slide. So how do you tackle it? These are the three important trials that have looked at the residual risk in non-statin agents. Improve it looked in terms of the ezetimibe, where the simvastatin ezetimibe compared to the monotherapy arm, the statistical significance though was achieved much later beyond third and fourth year, and ezetimibe combination led to a p-value less than 0.05 with a p of 0.016 to be precise. And when you were to look at in the Fourier analysis, or even for that matter Odyssey, both verevolucumab and the alirocumab in the PCSK9 inhibitors have looked at, the reduction had led to significant reduction of 15% each in reduction of hazards as compared to the control arm. Next slide. Now, these started lowering much earlier in the PCSK9 arm compared to say ezetimibe arm, and that's the reason is you want to achieve aggressive control and early control in these subgroup of patients. So the ESC guidelines in 2019 had talked about the score. When you look at the scoring technique, and if the patient's score is less than 1%, that's when you allow 116. But anyone between 1% to 5%, which would include, I believe, a lot of our Indian patients, including every diabetic, if they have your target would go to less than 100. For between the 5 to 10% of score, if the LDL is more than 190, or if the BP is more than 180, elevated risk factor with FH or CKD or diabetes with TOD, you will have to bring it down to 70. And if there is established ASCVD, now we know that the cutoff has been brought down to 55. And this should be whichever is lower with 50% reduction from baseline. So somebody whose LDL was 100 and he's only high risk or moderate risk, and you want to achieve 50% reduction, he would not be stopping at 70, but you will go to 50. And somebody whose was 70, now you would go down to 35 and not 55. Next slide, please. So the LDL target goals for the low risk is 116, moderate risk is 100, high risk is 50% reduction or less than 70, and very high risk is less than 55, especially no current statin usage likely to require high intensity LDL lowering, and current LDL treatment increase intensity, however, is required. Next slide. So the Lipid Association of India guidelines, they talk about major ASCVD when it is present age more than 45 in males and 55 in females, or you have family history of premature ASCVD, current cigarette smoking or tobacco use, or LDL low. In that subgroup, you find out and look at the high risk or other high risk if they are present. That's how the risk stratification by lie is done. So other high risk features are diabetes with one or two major risk factors, CKD, familial hypercholesterolemia, extreme of a single risk factor, coronary calcium more than 300, lipolitole more than 50, or non-steroid stenotic carotid plaque. And you have non-conventional risk factor, which are moderate risk, which is between the two, which is coronary calcium between 100 to 300, carotid intima media has increased 20 to 49, impaired fasting glucose, HSCRP more than 2, ApoB more than 110, or impaired increased waist circumference. Once you have done this, you can categorize based on this low risk, moderate risk, high risk, very high risk, and extreme high risk. Extreme high risk are category A and B, where CAD with one feature would fall into high risk. And if you have more than one feature with recurrent ACS, despite LDL less than 50, would fall into category B. Of course, the low risk is CVD risk less than 30%, lifetime risk, moderate is more than 30%, and high risk is more than 3 ASCVD or 2 major ASCVD with more than one major moderate risk, non-conventional risk factor, with very high risk being diabetes with more than 2 other risk, ASCVD or familial homozygous hypercholesterolemia. Next slide. So the consensus is that in the patient who are extreme extreme risk groups, the LDL target in category A would be less than 50-80, and you have to consider drug therapy for that goal of 50-80. For category B, it is 30 and 60. For very high risk, it is 50-80. For high risk is 70-100. Moderate risk is 100 and 130. Low risk is 130 and 160. So practically in India, you would require almost a majority of the population falling into the category of 100 and 130. And patients who are ASCVD, in Indian subset, you would be looking at targets of 50 and 80 for LDL and non-HDL cholesterol respectively. So LDL 50 and 30 is what is proposed by Lipid Association of India to 2020 consensus guideline compared to the 55 cutoff given by the American and the European Society guidelines. Next slide. So is a low LDL something something new? It's not. Almost all cholesterol and brain is dependent, we all know, for the local synthesis, and it's not dependent primarily on the uptake by circulation because of blood-brain barrier. And Hunter and Gartner had suggested their population base having no atherosclerosis. In that subgroup, we even know that even in the 7th, 8th decade, their LDLs remain in the range of 50 to 75. And the newborns, the LDL is around 30 to 70. So practically, we all have evidences of patients who are either born, we all are born with an LDL of 30-70, and we have hunters and gatherers, which we actually end up with the Aborigine Australians or the our anthropological ancestors, as you can call, whose mean LDL is 50 to 75. So a mean value cannot be considered as a new normal. The normal values have somehow migrated towards the upper level, and hence we actually need it to be much lower. Next slide. So the guideline talks about statins. We try to bring, if the LDL more than 50, add ezetimibe. Still more, then you can consider bempedoic acid, or you can choose a PCSK9 inhibitor. But we all know PCSK9s are very costly and not affordable, and hence we have now a choice of bempedoic acid. You must reinforce lifestyle. You should look at the very high risk group LDL to be kept below 50. Category A, you should keep it below 50, and category B below 30. And optimal control of diabetes and blood pressure is also very important. Next slide. So the limitation of current therapy is that almost nearly 50% patients do not achieve the goal. And with patients who have high baseline, very high CV risk is required, additional lipid lowering is required to optimize the lipid therapy. And the statins will have more than 50% patients will stop within 1 year of initiation, with associated 9 to 13% increased risk of development, with Fibraze being less effective in LDL lowering, the main role in the moderate to severe hypertriglyceridemia. PCSK are very costly, as it is less effective in CRP reduction used in monotherapy. Next slide. Hence, I think I conclude this, and we all know that what Dr. Manoj Chawla has covered, that how bempedoic acid can be positioned in all these subgroup of patients, be very effective therapy in choosing in our patients in two subgroups. One, those who cannot tolerate, and two, who don't achieve the target. So target is not achieved in majority, and that's why most of our patients would actually be eligible subgroup who can be given bempedoic acid. So 50% don't achieve the goal. You can either try ezetimibe or you can add bempedoic on top of statin. So my best preferred regime would be adding this top of statin. Nobody is asking to stop statin, but there is a substantial population which can be given this therapy on top of statins, because a lot of patients are not achieving the goal that they're desired to be achieving. Over to Dr. Amit. Thank you.
Sir, thank you so much, Chawla sir and Sharma sir, for the insightful webinar. Sir, I have a couple of questions, and 4 or 5 of the audience have asked about the liver safety and concomitant use with liver diseases, sir. Chawla sir, you are on mute.
Yeah, can you repeat the question?
Sir, about the liver safety and with concomitant use in liver diseases.
Right. So I think as I showed in the data there, that when you have mild and early hepatic impairment, which means Child's book criteria A and B, bempedoic acid is pretty safe to use there. It's only in patients with severe hepatic impairment which may have what is called criteria C. That's the condition you'll avoid it. So for both, in terms of hepatic renal, only in moderate impairment, bempedoic acid is found to be used. Because often in those conditions, you may be often to use statins. Only severe insufficiency.
Sir, can you hear us?
Yeah, please. Can you repeat?
Okay, you were not able to hear my answer?
Yes,
sir,
no, I
got a lot of cracking.
Yeah, couldn't get the question.
Sir, the question is...
Was the question for me or for Dr. Chawla? I didn't get it.
Sir, the question was that usage of bempedoic acid in concomitant liver diseases?
So
I think, yeah, Dr. Chawla, I think has already answered it, right?
I
Yeah, he has
already
answered it.
that. Yes.
I heard it. Yeah.
Yeah. Sir, how would your clinical practice be as per the approval? It's on top of fully tolerated dose of statin, which for atorvastatin is 80 and for Rozua is 40. So would you give full dose of statin and then come over to bempedoic acid, or for the fear of statin intolerance, say at Rozua 5 or 10, you would think of as adding a second agent?
Is that for Dr. Sharma or myself?
Sir, Manoj sir, please take that question, sir.
Statin intolerance should prevent you from up-titrating statin. What we did mention is for those who are not able to tolerate, you do. If patients can't tolerate it, or you have reached a high dose and yet the LDL is not at the target level, you will offer additional benefit of bempedoic acid.
Right, sir. Sir, Chawla sir, in one of the slides, you showed that bempedoic acid was causing a reduction in high sensitivity CRP levels. So, sir, as a clinician, how important and valuable is this information to you?
It is really important, as we understand that hsCRP is one of inflammation, and a lot of vascular conditions are actually immune inflammatory disorders. So reduction in inflammatory markers do give us the promise that they will have vascular benefits. It's just that time will tell whether we are able to see parallel benefits with drugs like bempedoic acid as statins have shown. But the fact that they are bringing down hsCRP and inflammatory markers gives us the promise that not just LDL reduction, but they would in general be contributing.
Any statin?
So at what dose? As in, so bempedoic acid has a single dose, and that's the beauty of it. It is 180 milligram, no up or down titration. So if a patient is intolerant to statin, either has ASCVD or has hypercholesterolemia, the LDL is much on the higher side, I'm going to use bempedoic acid 180 milligram once a day. That's one single good dose. So that's easy for usage and clinicians to remember as well.
Right, sir. Kamal sir, are you there? Okay, sir.
Yeah, am I audible?
Yeah, sir. Sir, in the algorithm that we use, would you place bempedoic acid before ezetimibe, after statin, or you would place it with statin and ezetimibe as a third agent?
I would put it as along with, most of the patients who require to be doing it better because of more evidence we have for a ACVD kind of improve it. So that way push it ahead. But then if patient for pretty fine. I think once series of trials evidence emerges.
Yes, sir. Right, sir. Chawla sir, would you also like to answer the question, bempedoic acid before ezetimibe or after ezetimibe?
Well, I think the evidence for bempedoic acid seems quite promising. With ezetimibe, we do have some more experience over the while, but the bempedoic acid evidence does look promising. I said it's early days for experience yet, but I may consider use of bempedoic acid because of hardly any safety concern and the benefits seen before ezetimibe.
Understood, sir. Sir, I think we all are waiting for the clear outcome study, which is expected this year or next year. And I think we will have much more clarity once we have the results of the clear outcome study, and maybe that can change the landscape of this particular molecule as well. Sir, what are your final words to the audience? I'll first take it from Sharma, sir. And in the meantime, if the audience has any questions, please type in so that we can take them here. So Sharma, sir, your final words to the audience.
One, let's understand the targets for LDL cholesterol reduction. We should be clear about that. Dr. Sharma clearly showed what the targets are. We have to be far more aggressive, especially in patients with ASCVD. We should not optimize the therapy. You started on a drug and then just let it be doesn't help. So you need to reach the targets. beyond statins tolerated, look at non-statin drugs. Bempedoic acid is coming out to be an extremely promising agent with great evidence there, not only in LDL cholesterol, but reduction of inflammatory markers in the pathogenesis of cholesterol and at working at a very important level before the level that statins work. So bempedoic acid to be considered as a great option. And I always say, when you have a new drug in the market, do not look at only the evidence which is presented from the studies. Be the first to use it for your patients and see the experience and benefit for yourself.
Right. So that was, I hope that it enlightens our audience. Sharma sir, are you there with us for final words to the audience? Kamal sir? Okay.
Yeah,
So,
hi. Am I audible?
yes, sir. So your final words to the audience.
Yeah,
And
I think
sir,
Bempedoic, as Dr. Chawla clearly mentioned, that we are far off from the guideline directed therapy for the vast majority of our population. So many patients are actually having ASCVD and they require their LDLs to be brought much lower, and statins will not achieve it. There is a residual risk, and that residual risk needs to be addressed and taken care of. And for that, you will require therapies like bempedoic acid. As I said, the clear evidences are emerging, and probably we'll come to know that there are subgroup of patients which actually have used where I've combined it with ezetimibe also, ezetimibe, statin, and bempedoic. So you'll require probably all three to bring it down to that drastic levels.
right, so that was a wonderful evening and a quick discussion we had, I think 45 minutes, and we did a lot of scientific insights, and I hope that it helped our audience and they will go a long way in transforming the patient care and dyslipidemia in India. I would like to pass on to Kanu for extending a vote of thanks. Okay, I think there's some technical glitch. So on behalf of Macleods Pharmaceuticals, I, Dr. Amit Kamra, would like to thank our audience, our technology partners, and our two esteemed speakers, Dr. Kamal Sharma and Dr. Manoj Chawla. With this, we all wish you a nice evening ahead.
Thank you for having me. Pleasure to be with you. Thank you, Amit. Thank you, Dr. Chawla.
Thank you so
Thank
much,
you,
sir.
everyone. Thank you, Kanu. Bye.
Thank you, Chawla sir. Thank you.
Thank you, sir. It was wonderful, sir. Though it took us just 45 minutes, but I think we have covered almost everything and addressed everything by the audience, sir.
Thank you, Amit. Take care. Looking forward to meet you. Bye.
Sure, sir. I'll do that, sir. Pleasure meeting you.